So I'm Matt Williams. I thought I'd just briefly introduce myself. So I'm a clinical oncologist. I work at Imperial. I spend about 2/3 of my time in clinical practice, and my clinical practice is now mainly based on neuro-oncology, so primary and metastatic brain tumours. But I did a PhD in computer science with Tony as my supervisor, and I have recently started the computational oncology lab at Imperial. That little abbreviation up there is what I put in when I'm lecturing to computer science departments. So it stands for I am not a computer scientist. So I come from a clinical background. I have a very strong interest in computer science and mathematics, but that's not my primary area of expertise. Really what I'm interested in is I'm interested in the use of computational tools to solve clinical problems. And the reason for that is because they scale and because they're transparent and reproducible. And actually I think this work is a nice demonstration of those three features. So specifically if we think about lung cancer is a big problem. So there are about 37,000 cases a year in the UK and 35,000 deaths. And that pattern is repeated worldwide, where lung cancer kills over 500,000 people. And many patients present with inoperable disease, or they may present with disease that is technically operable, but they're not fit for an operation, because if we think about the things associated with lung cancer, such as smoking, that can have other impact on patients' health, so that they're not fit to undergo a general anaesthetic and a major resection. So historically, from an oncological point of view, those patients who've got relatively limited disease but can't have an operation have had radical radiotherapy, and in broad terms we know that we get better outcomes with higher dose, better outcomes with shorter treatment time, and better outcomes if you add chemotherapy. But exactly what the best treatment is remains rather uncertain. And so when you look at the treatments around chemoradiotherapy for lung cancer, there are lots of variations, and people have tried lots of different things. So people have tried changing radiotherapy dose, the number of fractions, the dose per fraction, the total timing, and they've tried adding chemotherapy before, with, and after radiotherapy, and then in some combination of those. And it's worth saying that even with that treatment, and we're looking at 6 to 7 weeks of radiotherapy typically, and that's radiotherapy every day, the outcomes remain fairly poor. So median survival is about 15 months, 2-year survival is about 30%. And this is not a trivial treatment to give. So the treatment-related death rate is approximately 2%. So there are some difficult decisions to make. And they're often difficult decisions to make in a group of patients where we know there's a benefit in general to adding more treatment, but where patient fitness is obviously and often a significant worry. And there's good evidence for chemoradiotherapy in other tumours. So in head and neck cancer and cervical cancer, there's very clear evidence that the combination is better. But in lung cancer, the evidence is really less clear. So a while ago now, some people, so Noel O'Rourke and Fergus Macbeth and some others, did a systematic review through Cochrane, and that was published and then updated in 2010. So they identified 25 trials, and so what we did, because we were using a new aggregation technique, is we took their search strategy and we took their inclusion and exclusion criteria and kept them the same, and that allows us to make the comparison relatively comparable, and we updated the search. And so there were 3 new studies and an update, so we have results from 28 trials. And what we did is we considered each trial as a series of 2-arm comparisons. Now, if you have a 2-arm comparison, obviously if you've got a 2-arm trial, that's nice and easy. If you have a 3-arm trial, it means we compare arm A versus arm B, arm A versus arm C, and arm B versus arm C. So you actually end up with 3 pairwise comparisons. And we had an Excel spreadsheet, and we extracted data on age, country, stage, the treatment they had, and then their outcomes. So we looked at survival and toxicity. And in the end, we had 28 trials with just under 4,500 patients. We're looking at 43 two-way comparisons of 54 regimens. And then what we did is we decomposed each 2-arm indicator, 2-arm comparison, so that we can consider a single outcome indicator in turn. So if we take lung chemo rad, that might report 1 year survival, 2 year survival, grade 3 neutropenia, and grade 3 esophagitis as typical sort of outcome indicators. So if you have a trial that has 2 arms and reports those 4 indicators, we would end up with 4 outcomes from that trial. And we use that to generate arguments, the way that Tony's just shown, and we then considered preferences. And actually we took a very simple approach to preferences, so we labelled them an efficacy or balance, and I'll talk about those in a minute, and we considered some meta-arguments. So we considered meta-arguments around statistical significance. We also considered a meta-argument around the stage of disease. So most patients having chemoradiotherapy will have stage 3A and 3B non-small cell lung cancer, but a few trials have included people with stage 2 disease. And one of the problems with that is if you have a patient with stage 2 disease, you might actually end up looking at an evidence base that is largely drawn from patients with stage 3 disease, and there's a problem with how representative that is. And we also looked at the quality of the trial, which we assessed using the grade criteria, and we actually carried this out by implementing it in a prototype written in Python. So we generated a superiority graph for the treatments based on the preferences, laid it out using some open source software, and we briefly explored the impact of different preferences and meta rules. So when we looked at the effectiveness preference, we were only really interested in survival and response rates. So any outcome that improved either overall survival or response rates beat any other argument, whereas the balanced preference was about considering both survival outcomes and toxicity. And we use these really just as an exemplar of what you can do with the system. So this is the first graph, and I'm sorry it's so small, but it's always a struggle to fit it on one page. These slides will be available afterwards, and this figure is available in the paper from lung cancer. And I'm just going to point out 2 things. So hopefully people can see the pointer, but even if you can't, if you look towards the top right-hand corner, there's this central sort of node and spider. And the reason for that is that this central bit is 60 gray and 30 fractions, which is just radiotherapy alone. And that's the historical standard for giving radiotherapy for irresectable lung cancer. Yeah.
The good end, I think there's a pointer, isn't it?
This one?
Should we
try that? I don't know if people say this one here. Hopefully people can see that. This one here is the historical standard for giving radiotherapy for unresectable lung cancer. And you can see that a reasonable number of people have compared their treatments either to it directly or indirectly, like this one here, which has both compared something else and then compared it directly. But the other interesting thing is actually, I'm sorry, I'm just going to, if we look at this, actually what really is interesting about this is how disparate this graph is. So each of these pairwise comparisons represents an individual clinical trial, and most of them do not connect with the others. And actually this makes interpreting the evidence in lung cancer very difficult. And what's interesting about this is we know from a clinical point of view it's difficult to interpret the evidence because we don't have a clearly best treatment when delivering chemoradiotherapy in lung cancer. And what's interesting is when you look at this graph, I think it becomes reasonably clear why. So lots of people have gone off and done their own trials. So very disparate and very disconnected. What we then did is we looked at what happens. This is if you keep the preferences constant, say keep preference E constant and alter the meta rules, and you can see that there's some variation. Red is if it's a winning treatment and bluey purple is if it isn't. And you can see that as you alter the meta rules, you get some changes in which treatments are felt to be the best. And we did the same under the other preference rules. But one of the problems with this from a clinical point of view is although that graph showing that there are lots of differences between treatments is true, many of those differences are actually fairly small. So, and indeed some of them are very small. So therefore it felt slightly like we were taking a hair-splitting approach. And so what we did is we tried to come up with some slightly wider definitions of treatment. And of course this is what we do when we're doing any standard systematic review, which is we try and come up with some categories of treatment that make sense. So what we did is we took the existing treatment data and we just tweaked it slightly and grouped the treatment, and then we reran the analysis. So we grouped radiotherapy into conventionally fractionated, hyperfractionated, or twice a day, or hypofractionated, which from a clinical point of view is probably the three big groups. And in terms of chemotherapy, we looked at whether you had chemotherapy or not, when you had it, and whether it had a couple of particular drugs in. So the platinum-based drugs are the commonest. And when you group the treatments, as you might expect, it makes the graph more cohesive. So once you say that treatment A and treatment B, which are very similar to each other, are grouped under a wider node, as you'd expect, that very disparate graph begins to come together because some of the nodes merge. And so this is an analysis really at the most grouped level. So this is taking a fairly high level view of this. I'll just try to, okay. So it's taking a fairly high level view. So what we can see here is slightly cryptic, but where it says conv-frac, this is concurrent, so that's giving chemotherapy and radiotherapy together, and conventionally fractionated. And you can see that this is compared to multiple other treatment regimens. The labels on the arcs indicate which trial we're talking about, and I've used a fairly simple mnemonic so that we can trace that back to the trials. The red lines mean that if we take this group of treatment is thought to be better than that group of treatment, and blue means that they're considered equivalent. And so the interesting thing about that is when you group the trials, you do bring the graph together quite nicely, and that's quite reassuring. The other interesting thing about that is there's quite a nice direction to this graph. So this is conventionally fractionated radiotherapy with chemotherapy given alongside, and these are some other options. And this is just conventionally fractionated radiotherapy given on its own. And the interesting thing about that is that broadly fits with the findings of the Cochrane review from 2010. But of course what we get in here is we get some of the other things. So this is about giving induction chemotherapy, so chemotherapy before the radiotherapy, and then conventionally fractionated, and in fact you can see how it relates to some of the other treatment strategies. And I think from a clinical point of view this is quite nice, because we don't just come away with the headline that this is better than that. We can show where these other options that many of us from a clinical point of view might be used to giving, or may have read about, that there are good biological reasons why, for example, hyperfractionation should be beneficial. And there are, it's quite nice to be able to say, well, we have included it in the analysis, and this is where it sits. So we learned. Well, actually, we've learned a lot of things better than the historical standard. That's quite interesting. So it's not that hard to improve on the historical standard, but it's not clear what the best thing is. So we know that hyperfractionation is better, and so is giving chemoradiotherapy. So what we then thought is, well, why don't we choose the group of treatments that has the best support, and then within that, look for the best treatment within that group. So if we look at this, the group that has the best support is at the top here. But then, from a clinical point of view, this describes a group of treatment. But as a clinician, I can't prescribe someone concurrent chemoradiotherapy with conventionally fractionated radiotherapy. I have to make a commitment in terms of what drugs, what doses, what scheduling, how much radiotherapy I'm going to give, and how long I'm going to give it over. So I do need some guidance in terms of the individual regimen I want to use. And that's what we then did. And we found within that group at the top that one of the trials appeared to be better supported under either of our preference options and under all of our meta rules. And so our argument is that we know that group of treatment appears to be best, but within that group of treatment we found one trial regimen that appears to be better supported than the others, and therefore we would argue that that's probably represents at the moment, our best suggestion in terms of which treatment you should give within that regimen. So Tony and I have now presented, what is a novel method for representing and reasoning with clinical trial results. And I think the lung chemo-rad example is a very good domain for this. Lung chemo-rad is a very real world, very complex domain, and it's very difficult to handle. And I think the computational approach offers us a way to understand and to shape the literature in a nice, interactive, flexible and relatively intuitive way. We think it should probably be more commonly used. So we've got some areas for development which I'll skip over. I think there's an open question about where this fits into current approaches to knowledge aggregation. And in terms of our current work, we're currently expanding and updating the lung work. Although we started by following the Cochrane systematic review pattern for inclusion and exclusion, that actually ends up excluding lots of trials, and so we are in a fairly methodical and stepwise fashion gradually including larger groups of trials based on wider inclusion criteria, and we're also looking at new disease sites. So I spend a lot of my time clinically treating brain tumours, so we're looking at that, and I'm also leading a Cochrane network meta-analysis into the treatment of brain metastases. And again, this is a difficult, unclear area where there are lots of treatment options and no one's quite sure what is best. And the nice thing about that is within that, our Cochrane working group who are working on the brain mets network meta-analysis, we're going to do an absolutely standard network meta-analysis with some good statistical support, but everyone's also very keen to do the computational work alongside that. And one of the nice things about that is we should learn something clinical from it, which will be useful, but from a methodological point of view, it should also allow us to better understand exactly what the pros and cons of using argumentation versus a network meta-analysis are. I think the other interesting thing is that new clinical domains actually drive new theory. So when we start looking at some of the GBM examples, you get some interesting new theory coming out, which I've not seen really explored in the literature anywhere. But there are some ideas for looking at the future. We know there's a big concentration on randomised trials. We know that randomised trials are unrepresentative of the patient population. And going forward, Tony and I have had several conversations about how we do wider pieces of work looking at more widely available patient data. That's where I finish. Thank you very much.
Thank you very much, Tony and Max, and I hope everybody was able to follow that. I think sometimes GBM, I wasn't quite sure.
Sorry, GBM is glioblastoma, so it's the most common primary malignant brain tumour in adults. 2,500 a year of them in the UK. Average survival is 6 months, 15 months with aggressive multimodality treatment. So a nasty tumour which is important. Sorry.